start our scientific session with a doctor's prayer. So I'll request everyone to please stand up.
सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्तु मा कश्चित् दुर्भाग् भवेत् न तो हम कामे राज्यम न स्वर्गम न पुनर्भवम कामे दुख ताप्ता नाम प्राणी नाम आरती नाशनम. Thank you all. Please sit down.
So today we have got Dr. Vishrut Bharti sir. He has done his MBBS from Motilal Nehru Medical College, Allahabad in 2007. That was his joining date. And he has done his Master of Surgery from King George Medical College, Lucknow, and which he completed in 2016. He has done his MCH Urology from Indira Gandhi Institute of Medical Sciences, Patna, where he was a gold medalist. He has done his senior residency from RG Stone Urology and Laparoscopy Hospital, New Delhi, and then he has done his senior residency again in Rajiv Gandhi Super Specialty Hospital, and now he is a lead consultant in the Department of Urology and Andrology in Pulse Hospital, Gorakhpur. And he is also his hospital of Bharti Hospital, so he practices there. So please welcome sir, he would like to invite you. Thank you.
So very good morning to all of you. Before we begin, I would like to thank the GP. So I would like to begin with a vote of thanks to the whole GP Association, and especially Dr. Pratibha Gupta ma'am and Dr. AP Gupta sir to giving me this opportunity and this platform. So today we are going to speak about the urethral stricture disease, a disease where I feel a huge chunk of the patient do not receive the proper treatment that they should. During this presentation, we'll be talking about the definition of the disease, the related relevant anatomy, the etiological factors behind this, the clinical presentation of such patients, and the diagnostic evaluation that these patients should undergo, and the management strategies that are currently in use for the treatment of such patients. So what is a urethral stricture disease? Urethral stricture is a fixed anatomical narrowing in the urethra associated with varying degrees of spongiofibrosis. This narrowing leads to an obstruction in the urinary flow, which leads to all the symptoms and complications associated with this condition. But before we dwell into that, we'll look into the basic urethral anatomy. So this is a figure of a male urethra. So it's a tubular structure extending from the bladder neck to the external urethral meatus, and it's a tube for approximately a length of 25 centimeter, and it's divided into 4 basic parts. So it's the posterior urethra contains the prostatic and the membranous urethra, and the anterior urethra which is formed by the bulbous and the penile urethra. So the prostatic urethra is the proximal most portion and extends for the period of for a length of about 3 to 4 centimeter, and receives the opening of prostatic and seminal-vesical glands. The next comes the membranous urethra. This is the fixed and the shortest segment of the urethra, extends to for about 2 to 2.5 centimeter, and is located between the 2 urogenital diaphragms, surrounded by the male external urethral sphincter. More distally located is the proximal part of the penile anterior urethra, that is the bulbar urethra, extending for a length of 3 to 4 centimeter, and this is the widest portion of the urethra. Then is the penile urethra, which extends for a length of about 15 centimeter, and the terminal portion of this is ends in a narrowing, which is called the navicular fossa. Now the anterior urethra, that is bulbar and the penile urethra, have a very special structure in its wall. Here we can see it is lined by pseudo-stratified columnar epithelium, which forms pits at various places, which are called the gland of Fletters. Now the function of this gland is to secrete mucus and keep the surface moist, and this very gland plays a central role in the pathogenesis of inflammatory urethral stricture. We will see in the coming slides. So the urethral blood supply, another unique feature of this part of the body. So the main supply of the penis is formed by the common penile artery, which is the terminal branch of internal pudendal artery. The common penile artery first gives off the bulbar and the urethral arteries, which form the antegrade blood supply to the urethra. It further continues as the central cavernosal artery and its terminal branch as the dorsal penile artery. These supply both corpus cavernosa and end by arborizing into the glans penis, thus forming the retrograde blood supply of the urethra. Therefore, we can see the male urethra has a dual blood supply. Now, this dual blood supply forms the basis of extensive mobilization of the urethra, which is required for proper reconstructive procedures. Coming to the etiology of this disease. So, the urethral stricture is most commonly caused by iatrogenic procedures, which affects about 33% of the patient. Another 19% of the strictures are caused by traumatic events. 15% of the patients are affected by inflammatory pathology, and a big chunk of 33% are left undiagnosed from an etiological standpoint. So, the iatrogenic strictures are caused by various kinds of instrumentation, which lead to ischemia and pressure necrosis, or either inflammatory reaction of the urethral mucosa. There are the most common culprit procedures are transurethral resection of prostate and prolonged catheterization, which combined together are responsible for more than 75% of the incidence. There are other less common causes like cystoscopy, hypospadia surgery, open prostatic surgeries like radical prostatectomies. So, this etiology affects certain specific points of the urethra, like the point 2 and 3 in the figure correspond to proximal bulbar and the penoscrotal junction. These are fixed points in the urethra and therefore bear the maximum pressure during any iatrogenic procedure. The fourth point is the navicular fossa, which, as we had discussed, is the narrowest portion of the urethra and therefore again is most prone to pressure necrosis. So, the traumatic stricture event can affect both the anterior and the posterior urethra. Now, posterior urethral traumatic strictures are a whole different entity, and rather than being a stricture, they are more of a urethral distraction defect, and therefore I am not discussing it here in detail. So, we will focus on traumatic strictures of the anterior urethra, which occur by a very specific mechanism of straddle injury, which is a blunt force acting and crushing the anterior urethra, most commonly the bulbar urethra, against the pubic bone. This crushing injury ruptures the spongiosal tissue and the urethra, causing bleeding and formation of a perineal hematoma. When this hematoma heals, it leads to formation of a dense obliterative spongiofibrosis and a short segment stricture. The inflammatory strictures are most commonly caused by bacterial urethritis, gonococcal in context to developing and underdeveloped countries. Once a bacterial urethritis happens, it mostly affects the gland of Litters, which we have discussed before. This infection leads to formation of paraurethral abscesses, which ruptures into the spongiosal tissue. Once the healing occurs, it leads to scarring and spongiofibrosis, leading to formation of strictures. Now, these affected Litters gland are most commonly and are at the densest in the proximal and mid-bulbar urethra and the distal peline or the navicular fossa. So, these are the most common areas which are affected by inflammatory strictures. But this disease process doesn't stop there. It shows a creep up phenomena. By that I mean the proximal segment to the urethral segment proximal to this stricture experiences an increase in the urethral pressure in the and urinary extravasates, leading to further spongiofibrosis and can lead to even pan-anterior urethral strictures. So, lichen sclerosis is another condition which commonly causes inflammatory urethral strictures. It is a chronic inflammatory condition of the skin which primarily affects the prepuce to begin with and then progresses as white fibrotic patches on the glans, as can be seen in this photograph. It extends to involve the external urethral meatus and the navicular fossa. Once these most distal portion of the urethra are strictured, the stricture then creeps proximally and this is a common cause of pan-anterior urethral stricture, affecting the whole of the urethra. So, the clinical presentation of such patients is with lower urinary tract symptoms that are seen with any differential diagnosis which has a component of bladder outlet obstruction. They may present with weak stream, straining, frequency of urination, nocturia, inability to completely void their bladder, and occasional hematuria. If the disease is kept neglected, it might present with complications like recurrent UTI, acute and chronic retention of urine, urethral abscesses which might rupture onto the surface, leading to urethrocuteneous fistulas. When multiple, it is a condition known as water can perineum. Now, the increased pressure being generated by the bladder can be transmitted to either kidneys, leading to obstructive renal failure. Patient might present with overflow incontinence or nocturnal enuresis. Rarely though, patients might also present with sexual dysfunction. So any patient coming to us with such symptom complex needs to be evaluated in detail, and the purpose of such a diagnostic evaluation is primarily to obviously detect the presence of a stricture, and once we have done that, they should be evaluated for presence of the number of stricture, location and length of the involved urethral segment. Also we should look into the presence of various complications. So the first investigation one might do is a renal function test and a urine routine culture to rule out any possibility of concomitant urinary tract infection or renal failure. So the first specific investigation one might do in such patients is a uroflowmetry. Uroflowmetry is an investigation where we get a curve representing the flow pattern of the patient. So this is a normal bell-shaped curve which represents a non-obstructed flow of the urine. In a patient affected with stricture disease, we get a very typical uroflowmetry pattern which is known as the box or a plateau shape. This fixed peak flow of the urine suggests a fixed anatomical obstruction. Apart from this, the patient undergoes ultrasound of the KUB region for the assessment of bladder for presence of any complicating features like any diverticulum, bladder stone. We should measure a post-viral residual urine and also assess the kidney for presence of hydroelectronephrosis, which might be indicative of any obstructive renal failure. Once we have done this and we are suspecting the presence of a urethral stricture disease, the diagnosis is confirmed by a imaging study, which is the retrograde urethrogram. Now this is the investigation of choice for assessing the anterior urethra and gives us all the details about the characters of the stricture, number and the length of the urethra involved, and therefore is crucial for preoperative planning. Mind you that this is an invasive investigation and should be done under sterile precaution and antibiotic cover, and once a sterile urine has been ensured by a culture sensitivity. So a contrast is instilled into the urethra as shown in the figure with a unique posture of the patient. The patient is kept in an oblique position at 45 degree with the dependent leg being bent so as to avoid any overlap with bony structures. So this is how a normal retrograde urethrogram would look. So we can see the distal portion is the pendulous or the penile urethra. The curvaceous portion is the character of a bulbar urethra. We can see a natural curvature on this natural bend. This signifies the penoscrotal junction, and this is a natural bend. This happens because of the suspensory ligament in this region of the penis. The proximal bulbar urethra ends with a conical segment which leads to the thin membranous urethra. Now this does not signify the caliber of this bulbar urethra. It is just that it is surrounded by sphincters, therefore it is not distended in this study. So here are some of the pathological pictures of retrograde urethrogram. The first one shows a short segment bulbar urethral stricture pointed out here by a star. So this is a short segment extending for a period of, for a length of about 1 centimeter. Now this is a filling defect you can see, which is signifies the verumontanum as a normal finding on RGU studies. Here is another study which it is a totally obliterative distal bulbar urethral stricture requiring reconstruction. This is another stricture. This is a very long segment stricture. We can see multiple rings, which signifies a pan-anterior urethral stricture. You can see these are a sawtooth-like appearance, which signifies presence of underlying lichen sclerosis, which you had already seen. So this was the assessment of the anterior urethra. To assess the posterior urethra, the bladder neck, and the urinary bladder, the adjunct investigation that must be done is a micturating cystourethrogram, that is the MCU. So once these investigations are done, more or less we have all the information we need for deciding on the management of the patient. But there are further few investigations like urethrosonography and MRI, which can give a detailed assessment of the presence of spongiofibrosis. But there is no further additional information that which we already have with an RGU and MCU. Therefore, the practical applicability of such investigations is limited and is generally not done. So once we have all these investigations, we need to decide upon the management. First of all, let me clear that there is no medical treatment for this pathology. It's purely a surgical disease, and the surgical modalities that are at our disposal are the minimally invasive modalities, which includes urethral dilatation and DVIU. Then are the reconstructive surgeries. So urethral dilatation is probably the oldest form of treatment of this disease and is based upon the concept of stretching the scar tissue without causing any further trauma, because any further trauma will lead to further and more severe spongiofibrosis, leading to recurrence of such strictures. So it must be done over multiple serial sessions and with increasing dilatation. It can be done by various dilators, as one can see in the photograph. The first one is a Lister metal dilators, which are most commonly used. Other forms of dilators like filiform dilators or balloon dilators are also being used nowadays. But even though this is a commonly used modality, it has been largely abandoned by the current literature and guidelines, and should only be practiced when options of DVIU and reconstructive procedures are not available. Even though it has been abandoned by current guidelines, it still continues to be frequently used in the Indian scenario, probably because of lack of availability of endoscopic and advanced reconstructive procedures. So DVIU, meaning direct visual internal urethrotomy, is the only endoscopic management we have, and involves a sharp incision into the urethral stricture to release the scar tissue, as can be seen in the photo. This allows creation of a large bore lumen, and once we have created this, we put a large bore catheter. These incisions can be given at various positions, 12 o'clock being the most common and preferred approach. But in the recent past, there has been literature supporting the use of 6 o'clock position, especially in the bulbar urethra, because of the thick spongiosal tissue available there. 4 and 8 o'clock and multiple radial strictures are also the options to create such a large bore lumen. Once this lumen has been created, an indwelling catheter is placed over a guide wire and is left in place for a period of 3 to 7 days, depending on the caliber and amount of spongiofibrosis. Although it's a very safe procedure, it has certain complications like hemorrhage and perineal hematoma. Serious complications like rectal injury and incontinence of urine are rare but might occur. So the outcome of this procedure varies highly across the literature. Success rates of about 20 to 80% have been reported, depending on various types of stricture. A systematic review has quoted the success rate of this procedure to be 74%, but very specifically for bulbar urethral strictures of less than 1.5 centimeter, which are not associated with dense spongiofibrosis. The problem with this procedure is that with subsequent repeated procedure, the outcomes are much worse, and a second DVIU might have a role in short-term relief, and third and further any further attempts have absolutely no role in the management of strictures. So it has a very specific role in the management of stricture, that is for the first time treatment of short segment bulbar urethral stricture with a minimal spongiofibrosis. It might also be used for anastomotic strictures occurring after urethroplasties. So coming on to the reconstructive surgeries. So these are the type of surgeries which are the definitive treatment of stricture disease and provide long-lasting durable results. The first among urethroplasties is the anastomotic urethroplasty, which is known to provide the most durable and long-lasting effect. But this is subject to the condition that all fibrotic segment of the urethral stricture wall is excised and a healthy tension-free anastomosis is made between the healthy ends of the urethra. So this is possible only if the stricture is in the bulbar urethra and extends only for a segment of 1 to 3 centimeters. So during the procedure, an perineal incision is given, the bulbospongiosus and the bulbocavanosus muscles are incised, the urethra mobilized, and the disease segment excised. Once the disease segment has been excised, a spatulated patulous anastomosis in 2 layers is completed between the healthy ends of the urethra. So this is a case that we did. This was a young 28-year-old male that presented to me with a short segment stricture on RGU. He had a very specific history of straddle injury 2 months before the presentation of the patient. So even though the stricture is a very small segment and located in the bulbar urethra, rather for going for a DVIU, we straight away went for an anastomotic urethroplasty. In the photograph, you can see that we notice a band, a wasting of the urethra, which signifies dense spongiofibrosis, a condition where DVIU would not have been a success. So the urethra was mobilized and a patulous anastomosis created. So I've been following this patient for 2 years, and the patient is presently doing well with a good uroflow and no obstructive symptoms. So it is a very good outcomes with success rates of 86 to 98% reported in literature. Though it is associated with certain complications like bleeding, hematoma, and the most dreaded one is the recurrence of stricture. Now, due to division of the vascular spongiosal tissue, erectile dysfunction, ejaculatory dysfunction, and decreased glans sensitivity are complications associated with this procedure due to the vascular neuronal damage. This is the reason why that this treatment option is falling out of favor, especially in young sexually active males. The second one is the augmentation or substitution urethroplasty. Now, this is the special feature of this urethroplasty is that we do not transect the very much vascular spongiosal tissue or the urethra, which saves the vascular and the neuronal damage that might have occurred in the anastomotic urethroplasty. What we do is the narrow urethral lumen is augmented with a local tissue transfer. The tissue transfer can be in the form of a graft or a flap. Another advantage of this procedure is the wide range of applicability, and almost all kind of strictures can be successfully treated with this form of urethroplasty. It can be divided in various types based on the area where the graft is placed. Like if the graft is augmented ventrally, it's known as a ventral onlay, dorsally dorsal onlay, or if dorsolaterally, a dorsolateral onlay. Now the final outcome of all these types have been similar in the available literature, and therefore the choices between them is comes down to the surgeon's choice. So augmenting tissue can be taken from various sources like oral mucosal grafts, inner preputial grafts, so bladder or rectal mucosa. Now bladder or rectal mucosa are difficult to obtain, are associated with major morbidities, and do not have very good results. So currently the graft material of choice is the oral mucosal graft, which can be harvested either from buccal, labial, or the lingual regions. What makes these oral mucosal grafts best suited is their ability to readily adapt to the wet environment of the urethra, because they are already in a wet environment of oral mucosa. It is easily harvested, the donor site is concealed, and there is no cosmetic issues. The vascular characters of the buccal graft also make it readily adaptable to the recipient site. Inner preputial skin also is a viable option and has good results. Then there are local flaps used for this reconstruction, like the vertical penile skin flap or the transverse circumferential skin flap, which have also shown good results. So again, the exposure is same as the anastomotic urethroplasty, a midline perineal incision, division of the muscles, and then a urethrotomy is made. After the urethrotomy is made, it is augmented with a graft, as can be seen in this diagram, and a large bore lumen is created over a 16 or a 14 French catheter. Now I should mention the main side effects of this procedure of erectile dysfunction and ejaculatory dysfunction are due to division of this red muscle that we can see here, and therefore in the current practice muscle sparing approaches have been taken up more commonly to prevent this side effect. So this is a case that I did about 2 months back. So this patient presented with changes of lichen sclerosis. There was a complete meatal stenosis, and a stricture was seen in the mid to distal bulbar part extending into the proximate penile area. But during intraoperative endoscopy, it was diagnosed as a pan-anterior urethral stricture. We decided to proceed with a augmentation urethroplasty. The urethra was mobilizing with a muscle sparing approach. So we can see here only this portion of the muscle was divided, while this portion, which has a function of ejaculation, pushing this seminal fluid forward during ejaculation, was preserved. Once the urethra was mobilized, a urethrotomy is done, and a long buccal mucosal graft was used to reconstruct this strictured urethra. So this is the photograph of the same patient taken about 2 months after surgery. We can see the red area which signifies a good graft uptake here, and this is the uroflowmetry, post-operative uroflowmetry after 1 month of surgery, which shows a good bell-shaped curve. These might be artifacts, so are not significant, and these show a non-obstructive curve with a max flow of 50. So the patient is doing well, but still needs to be maintained in follow-up. So outcomes of this procedure are very good, with success rates of around 85% reported in the literature. Now, since the success of the procedure is based on the survival of the graft, so success rate is seen to progressively reduce over time. And most common causes of failure are anastomotic strictures, those ring type of strictures that occur at junction of the grafted area and the native urethra. The main complications associated with are bleeding, perineal hematoma, and perineal infections. Recurrence of stricture will always be associated with any kind of urethroplasties. Erectile and ejaculatory dysfunction can occur, but they are much less as compared to anastomotic urethroplasty, and have further been reduced with use of muscle and nerve sparing techniques. Now, staged urethroplasty. Some urethral strictures are not amenable to single stage repair and therefore are completed in 2 stages. So, the first stage involves exteriorizing of the diseased urethra. This can happen in various types, like the Johansson's first stage repair, which includes marsupialization of the diseased urethra to the adjacent penile skin. This is the penile skin anastomosed to the diseased urethra, or can be done in conjunction with laterally placed grafts, which help broaden the new urethral plate and easier reconstruction in the second stage. Another type is the ASOPA first, where a graft is placed inside the plate. So once the first stage is complete, a second stage is taken up about after 4 to 6 months, and tubularization of the neo-urethral plate is done over a good size catheter. So indications of this procedure have gone down. The use of this procedure has gone down with presence of advanced reconstructive techniques, but still there are scenarios where this is indicated, like where the residual urethral plate of less than 6 French, multiple episodes of prior failed urethroplasties or hypospadias repair, and history of urethrocutanous fistula or abscess leading to very diseased and fibrotic urethras. The last among the reconstructive procedure is a palliative procedure, which is done in patients who are unable to tolerate such long reconstructive surgeries. Here we bypass the whole strictured segment of the penile and bulbar urethra, and the bulbomembranous junction is exteriorized to the perineal skin. The patient squats down and to void. Now only the short segment of urethra in use decreases the chances of recurrence, and even if the recurrence occurs, it can be easily managed by urethral dilatations, although the chances of recurrence are minimal. So it is mainly indicated for old frail patients who are unfit for long reconstructive surgeries or have had multiple failed attempts at urethroplasties, and there is a paucity of tissue material for reconstruction. This completes all the surgeries that a urologist should have in his armamentarium to deal with such strictures. Now, a small mention about the female urethral stricture disease, which is a definitive entity, although rare, and affects only about 10% of the females presenting with bladder outlet obstruction. Now, the basic pathophysiology, etiological factors, diagnostic and treatment, the basic principles remain same as the male stricture disease, although there are certain differences. Like in the etiological factors, an added factor is the trauma sustained by females during the vaginal delivery or during obstructed labor. In the diagnostic approach, pelvic examination remains paramount, and to rule out other differentials of bladder outlet obstruction like vaginal prolapse, cystocele, or presence of meatal stenosis, which are readily visible on a thorough pelvic examination. In the imaging, RGU, which played a central role in male urethral stricture disease, has no role here because of the short urethral length. And the main diagnostic modality is VCUG or the NCU that we have already discussed, avoiding cystouretrogram, which helps delineate the distal stricture and also assesses the bladder and the proximal dilated segment. Once it has the stricture has been diagnosed, the main first line of treatment remains urethral dilatation, a modality that had been abandoned in the male urethral stricture disease. But here also the success of this treatment remains only 45 to 50%. And if the stricture is recurring after multiple episodes of urethral dilatation, the definitive treatment remains urethroplasty, which gives very good results with the use of local tissue flaps or grafts. Coming to the take-home message of this talk, so first of all, we need to prevent such strictures from happening. What the central role in preventing stricture formation is the practice of stave catheterization, which should be done in gently and in trained hands, should be done in sterile environment with use of generous lubrication. The catheter should be ensured to be in the correct position before inflation of balloons, and one should limit the indwelling time of the catheter. Now, catheter material also plays an important role, with silicone being the best possible material that we can use. The most commonly used material is latex, and rubber is completely not recommended for use of indwelling catheter. If the patient has to be on long-term catheterization, silicone is the material to be used. But once the stricture has occurred, one should aim for an early and definitive management of procedures. And we see that in our society, there has been an overuse of minimally invasive techniques of urethral dilatation and DVIU. What this does is there is high rate of recurrences, and with multiple procedures, the health of the urethra further deteriorates. So if a stricture has occurred, there should, and failed after such minimally invasive procedures, the role of timely referral to a center equipped with urethroplasty techniques is paramount, which helps give good final outcomes. Thank you. So small quiz. So the first question is, the shortest part of the urethra is? So membranous urethra. Membranous urethra traverses for a length of 2 to 2.5 centimeter. So which unique anatomical feature of the urethra allows its free mobilization during reconstructive surgeries? Long urethral length, adjacent highly vascular corpora cavernosa, dual blood supply, or the neovascularization? Dual blood supply. We've seen that there is both antegrade and retrograde blood supply. Third is, what makes the buccal mucosal graft best suited for urethral reconstruction? Actually, all of the above. So it is easy to harvest. It's located in the buccal mucosa, and it's a pan-laminar vascular plexus, which makes it easy uptake on the recipient site. The characteristic pattern of urethral stricture on uroflowmetry is? No, bell-shaped is the normal urethral flow. So box-like pattern. The urethral flow rises, and due to a fixed anatomical obstruction, it plateaus up. So there are other flow patterns which one might see, like low peak and prolonged curve, which are seen in benign prostatic hyperplasia, BPH, and staccato patterns are seen in dysfunctional voiding, neurological condition. So best catheter material for prolonged catheterization? Silicone. Easy one. So thank you.
मुलाकातें होती रहें, प्रेम की बातें होती रहें, मुलाकातों में मजबूरियां ना हो, गलतफहमियों के लिए दिल में जगह ना हो, खुश रहने की वजह हमेशा साथ हो. थैंक यू. बहुत छोटी है और खत्म.
For the cystourethrogram and the
आंखें वही देखती हैं जो वे देखना चाहती हैं, मन वही सोचता है जो वह सोचना चाहता है. आंखों में बसी तुम्हारी तस्वीर बहुत खास है, ऐसा लगता है तुम सदैव मेरे पास हो. हाँ, थोड़ा ज़्यादा रोमांटिक हो गया ये.
इसीलिए तो बहुत
तेज क्लैपिंग हुआ है. और बस लास्ट समय. हाँ, समय बहुत बलवान है और समय हमेशा कम, और हम लोग परेशान रहते हैं समय के साथ. और थोड़ा वक्त मिल जाता है, समय मिल जाता है, हम ये कर लेते हैं, वो कर लेते हैं, लेकिन उतने में सब कुछ हो गया. आज के अटेंडेंस देखे तो बहुत अच्छा लग रहा है, सब कुछ समय मिल गया आने के लिए. इट्स वेरी नाइस. समय उचित या अनुचित नहीं होता, समय को उचित बनाना पड़ता है. उदास लम्हों को स्वीकार कर उन लम्हों को जीने की कोशिश करनी पड़ती है. कभी कभार गम के आंसुओं को भी पीना पड़ता है. अच्छे बुरे हर हाल में हमें जीना पड़ता है. थैंक यू. एक ग्रुप फोटो हो जाए. ये उन्होंने ट्रेंड शुरू किया है.
अभी भी लग रहा है कि ये जो ब्लैडर आउटलेट ऑब्स्ट्रक्शन चाहे BPH से हो, चाहे ब्लैडर नेक ऑब्स्ट्रक्शन से हो, चाहे सिंपल फेमोसिस से हो या यूरेथ्रल स्ट्रक्चर डिजीज से हो, पेशेंट तो सिमिलर सिम्टम्स से आएगा. उसको लगेगा कि भाई यूरिन कम हो रहा है, धीरे धार कम बन रही है, फ्रीक्वेंसी है, नॉक्चूरिया है, ये सब सिम्टम्स कॉमन है सारे पैथोलॉजी. बट एक बार जैसे यूरोफ्लो किया, अगर हमें सस्पिशियस है, बॉक्स लाइक पैटर्न आ रहा है, वी आर सस्पेक्टिंग कि ये स्ट्रक्चर हो सकता है. या फिर BPH का पेशेंट है, वी हैव बीन ट्रीटिंग हिम फॉर BPH, ही इज़ नॉट रिस्पॉन्डिंग, तो प्रॉब्ली आइदर द प्रोस्टेट इज़ नॉट रिस्पॉन्डिंग, और क्या है कि कोई और कॉन्कॉमिटेंट स्ट्रक्चर भी हो सकता है. तो ऐसे सिनारियो में वी विल प्रिस्क्राइब RGO एंड MCU. तो फिर वो कैरेक्टराइज कर देगा कि भाई कंट्रास्ट कहीं भी कंस्ट्रिक्शन दिख रहा है तो इट्स अ स्ट्रक्चर डिजीज.
सर कितने परसेंट केसेस में यदि स्ट्रक्चर है पीवीआरयू बढ़ा होता है परसेंटेज वाइज, जैसे हम लोग अल्ट्रासाउंड कराते हैं उसमें यदि पीवीआरयू बढ़ा हुआ है तो हम लोग डेफिनेटली लट्स के बारे में सोचेंगे। तो कितने परसेंट केसेस में यदि प्रोस्टेट का अलाइनमेंट नहीं है या मीडियन लोब का अलाइनमेंट नहीं है तो कितने परसेंट केसेस में स्ट्रक्चर होता है विदाउट प्रेजेंटेशन, पीवीआरयू ना बढ़ा हो स्ट्रक्चर प्रेजेंट होता है?
तो परसेंटेज से ज़्यादा बात ये है कि स्टेज ऑफ प्रेजेंट, मैं बता रहा हूँ स्टेज ऑफ डिजीज से ज़्यादा है कि जैसे अगर अर्ली सिम्टम्स पे ही अगर इनिशियली सिम्टम आए पेशेंट को हमारे पास आ गया, पीवीआरयू बढ़ता क्यों, पहले ये डिस्कस करते हैं। क्या है कि कंपनसेटरी हाइपरट्रॉफी हो जाती है ब्लैडर की, अब एक ऑब्स्ट्रक्शन के अगेंस्ट काम करना पड़ रहा है, सो इट हैज़ टू वर्क मोर। सो आफ्टर अ सर्टेन स्टेज 1 साल 2 साल तक पेशेंट्स उसको चलाते रहते हैं, तो क्या होता है कि द फर्स्ट स्टेज इज अ ब्लैडर हाइपरट्रॉफी, ब्लैडर वॉल थिकनेस बढ़ जाती है, ठीक है, मतलब 4 mm 5 mm तक नॉर्मल है, उससे ज़्यादा ब्लैडर वॉल थिकनेस है मतलब पैथोलॉजिकल है, तो ब्लैडर वॉल थिकनेस बढ़ती है। बट आफ्टर सर्टेन पॉइंट टाइम द ब्लैडर टायर्स आउट। कई बार पेशेंट्स को साथ में डायबिटीज़ भी है तो अगेन डायबिटिक सिस्टोपैथी है, तो ब्लैडर थकने लग रहा है, नाउ इट इज़ नॉट बीइंग एबल टू जनरेट द सेम काइंड ऑफ प्रेशर विच इट यूज टू, तो फिर वो ब्लैडर में यूरिन बचने लगता है। दैट इज़ व्हाट इज़ पीवीआरयू। पीवीआरयू का असेसमेंट इस पॉइंट ऑफ व्यू से होना चाहिए कि अगर पीवीआरयू है तो इट इज़ इंडिकेटिव ऑफ 2 काइंड्स ऑफ पैथोलॉजी, या तो कोई डिस्टल ऑब्स्ट्रक्शन है, क्योंकि सब लोग यूरोफ्लो नहीं कराते, बहुत कॉमनली प्रेजेंट भी नहीं होता है, तो अगर पीवीआरयू बढ़ रहा है तो कोई टाइप ऑफ ऑब्स्ट्रक्शन हो सकता है, इट माइट बी बीपीएच, इट माइट बी स्ट्रिक्चर, इट माइट बी ब्लैडर नेक ऑब्स्ट्रक्शन, कुछ भी हो सकता है, कोई भी लॉन्ग स्टैंडिंग ऑब्स्ट्रक्शन हो सकता है। बेस्ड ऑन इंक्रीज पीवीआरयू वी कैन नॉट से कि इतने परसेंट में स्ट्रिक्चर में होता है या इतने परसेंट में बीपीएच।
इनिशियली प्रेजेंटेशन विदाउट इंक्रीज पीवीआरयू हो सकता है?
हो सकता है, अगर अर्ली स्टेज में पेशेंट आ रहा है और कोई और कोमॉर्बिड फीचर्स नहीं है तो इट कैन वेरी वेल हैव अ नॉर्मल पीवीआरयू। तो सिम्टम्स को मेनली जज करना है, इसीलिए क्या है कि अगर कोई पेशेंट लोग किसी भी टाइप ऑफ लोअर यूरिनरी सिम्टम से आ रहा है तो वन मस्ट ऑलवेज प्रिस्क्राइब दिस बैटरी, बेसिक बैटरी ऑफ इन्वेस्टिगेशन, जिसमें रीनल फंक्शन होना ही है, यूरिन रूटीन एटलीस्ट होना ही है, यूरोफ्लो होना है और अल्ट्रासाउंड, ताकि ऐसा नहीं कि पीवीआरयू नहीं आया तो हम मिस कर गए, पीवीआरयू नहीं आया तो यूरोफ्लो पकड़ लेगा, यूरोफ्लो नहीं पकड़ पाया तो सिम्टम्स या फिर रिकरेंट जो यूटीआईज हो रहे हैं वो पकड़ सकते हैं, तो ये सब डाउट उठाएगा।
यूरेथ्रल स्ट्रिक्चर और प्रोस्टेटिक ऑब्स्ट्रक्शन दोनों में कैसे क्लिनिकली डिफरेंशिएट करेंगे?
डिफरेंशिएट वैसे देखिए डेफिनेटिवली तो नहीं डिफरेंशिएट कर सकते, ओनली बेस्ड ऑन सोली ऑन कुछ फैक्टर्स होते हैं, कुछ सिम्टम्स होते हैं विच माइट सजेस्ट अस कि ये हो सकता है ये स्ट्रिक्चर का हो सकता है प्रोस्टेट। फर्स्ट इज एज, अगर यंग पेशेंट आ रहा है लेस देन 50 ईयर्स ऑफ एज तो फर्स्ट डिफरेंशियल आई वुड कीप एज अ स्ट्रिक्चर रादर देन बीपीएच, ठीक है। अगर ओल्डर पेशेंट आ रहा है तो दोनों की ही पॉसिबिलिटी इक्वल रहेगी। इसके अलावा जो स्ट्रिक्चर डिजीज़ के पेशेंट होने ऑब्स्ट्रक्टिव सिम्टम्स ज़्यादा होते हैं, स्पेसिफिकली वो कंप्लेन करेगा कि धार बहुत पतली हो रही है, बहुत जोर लगाना पड़ रहा है, इतना जोर लगाना पड़ रहा है कि लैट्रिन तक हो जाता है। इस तरह के सिम्टम्स जनरली हम लोग देखते हैं स्ट्रिक्चर डिजीज। प्रोस्टेट वाला पेशेंट क्या आएगा कि शुरुआत करने में प्रॉब्लम हो रही है, रुक रुक के हो रही है, या फिर ही माइट ऑल्सो कंप्लेन ऑफ इरिटेटिव सिम्टम्स, मतलब रात को उठना पड़ रहा है 2 बार 3 बार 4 बार, अर्जेंसी हो रही है, लग रहा है तो एकदम भाग के जाना पड़ रहा है, जाते जाते 1-2 बूंद लीक कर जा रहा है, विच आर लेस कॉमनली सीन इन स्ट्रिक्चर। इसके अलावा फिर हिस्ट्री भी लेते हैं, जैसे अगर हिस्ट्री ऑफ कोई रिकन्स्ट्रक्टिव प्रोसीजर पहले ही है, हाइपोस्पेडियस रिपेयर का पेशेंट है, या फिर कोई इंस्ट्रूमेंटेशन की हिस्ट्री है, टीआरपी पहले हो चुका है पेशेंट को, या लॉन्ग टर्म किसी वजह से कैथेटराइजेशन हो चुका है, तो देन अगेन वी विल कंसिडर पॉसिबिलिटी ऑफ स्ट्रिक्चर डिजीज। मगर कोई ऐसी डेफिनेटिव फैक्टर नहीं है कि हम ये कह सकें कि ये हुआ तो हमें स्ट्रिक्चर ही है या ये हुआ तो हमें प्रोस्टेट है, वो तो इन्वेस्टिगेशन पे ही पता है।
Structure was very common.
Yes.
Nowadays it is coming very less. Most probably.
because
What is the ratio today's?
it has reduced जैसा 15% बोला, इस 15% में भी only 6 to 8% in Indian scenario is caused by gonococcal. Rest of the 7 to 8% are for lichen sclerosis. क्योंकि अब अर्ली ट्रीटमेंट हो जा रहा है, टाइमली ट्रीटमेंट हो जा रहा है, प्लस इंसिडेंस ऑफ सेक्सुअली ट्रांसमिटेड डिजीज ऑल्सो रिड्यूस्ड, तो गोनोकोकल का जो पोर्शन है, जो कंट्रीब्यूशन है स्ट्रिक्चर डिजीज में, इट हैज़ डेफिनेटली रिड्यूस्ड इन द इंडियन सिनेरियो, स्पेशली इन अर्बन पॉपुलेशन।
ओल्ड एज कितने दिन तक कैथेटर रख सकते हैं, चेंज करना है फॉर इनकॉन्टिनेंस अगर कैथेटर बड़ा हुआ है?
मैडम अगर इनकॉन्टिनेंस हो रहा है, कोई ऐसी डेबिलिटेटिंग कंडीशन है जो उसका डेफिनेटिव मैनेजमेंट नहीं हो सकता है, तो यूरेथ्रा में मतलब वो तो फिर लॉन्ग टर्म कैथेटराइजेशन कैटेगरी में आ गया। कैथेटर शुड बी चेंज्ड एवरी 4 वीक्स। और अगर वी आर जजिंग, जैसे स्पाइनल इंजरी के पेशेंट हैं, बहुत डेबिलिटेटेड हैं, दे आर नोन टू नॉट have a definitive cure. So better to shift the patient to a suprapubic cystoscopy rather than a urethral catheter. क्योंकि क्या होता है कि फिर उसका आपको बार बार हर हफ्ते आपको यूज़ करना है. You will not go to a hospital. Patient might not go to a hospital. वो कंपाउंडर आके घर पे बदलेगा, which will cause trauma, फिर further problems. तो better to shift in an elective manner to the patient to a suprapubic cystoscopy. उससे discomfort कम हो जाता है, urethra का health maintain रहता है, and it is easier to manage.
Many times, if you want to change the urethral catheter, it doesn't come audio. So it happens because if you put for the longer time. So you're right, like the patient, like the paralysis and this sort of patient, this is a suprapubic catheterization.
The suprapubic catheter is always better for long-term catheterization. और जो सर ने मेंशन किया कि वो होता नहीं, that is mostly because कि हम लोग 99% of the times हम लोग क्या इंजेक्ट करते हैं उसमें, उसके वेल्व में बलून में NS, तो उसमें वो सोडियम का सेडिमेंट हो जाता है and it blocks the valve. इसीलिए ideally it is recommended to use distilled water. Even though it has अगर हो भी गया है तो अल्ट्रासाउंड से देख के we can puncture the suprapubic noodle से करके, that's not a big complication, वो तो बहुत easily deal हो सकता है.
Previously, it was said, like the optical internal ureterotomy we used to do. Now the term had been changed. I think they had used mentioned.
OIU भी कॉमन टर्म है, वो ऐसा कुछ नहीं है कि वन और दी अदर, दोनों यूज होता है. OIU भी यूज होता है.
मैं एक्चुअली आगरा का ग्रेजुएट पोस्ट ग्रेजुएट, तो आई remember the days of Dr. Asoka. He was my teacher. Recently, he
Legend
died.
of urology.
Yeah,
Legend of
yeah,
Indian urology.
Legend of urology. His name has been mentioned in all the textbook of urology. So I remember him as he was my teacher for 10 years. We have been in. I have been in Agra Medical College. So at the same time, I want to ask you one question: that what is the result of super urethroplasty?
सर अच्छा है रिजल्ट, मगर आजकल जो टेक्निक मोर कॉमनली एक्चुअली क्या है, असोपा में देयर इज वन फिगर में दिखाना है. तो असोपा ये है द वन ऑन द राइट साइड. तो क्या है कि इसमें हम देख सकते हैं कि यूरेथ्रल जो रेजिडुअल यूरेथ्रल प्लेट है उसको डिवाइड कर दिया है एंड वी आर पुटिंग अ ग्राफ्ट इनसाइड ऑफ इट. सो फॉर दिस टू बी एन एलिजिबल ऑप्शन, जो नेटिव यूरेथ्रल जो बची हुई यूरेथ्रल प्लेट है, जो स्ट्रिक्चर्ड यूरेथ्रल प्लेट है, हैज़ टू बी ऑफ एटलीस्ट 10 mm. तभी तो डिवाइड करेंगे. अगर 6-7 mm की है यू कैन नॉट डिवाइड एंड क्रिएट अ स्पेस बिटवीन. तो इसकी एप्लीकेबिलिटी थोड़ी कम हो गई है इन प्रेजेंट सिनेरियो. तो जो आजकल है अनदर स्टॉलवर्ट ऑफ इंडियन यूरोलॉजी, कुलकर्णी, डॉक्टर कुलकर्णी इज बेस्ड इन पुणे. सो कुलकर्णी यूरेथ्रोप्लास्टी इज द मोस्ट कॉमनली प्रैक्टिस्ड काइंड ऑफ यूरेथ्रोप्लास्टी दीज डेज. जिसमें जो मैंने ये फोटो दिखाई थी, इसमें वो डॉर्सोलेटरल ऑनले करना है, मतलब वो खोल दिया यूरेथ्रा को और उसके ऊपर उसको ऑगमेंट कर दिया. दिस इज बारबगली और कुलकर्णी यूरेथ्रोप्लास्टी इज इट इज कॉल्ड.
Any more question?
We have many questions.
Vishrut, it was very nice presentation and diagrams were so good. अरे हम लोगों को भी समझ में आई, गायनी वाले लोग भी कुछ देख के लग रहा, it was very interesting to see all photographs.